Good afternoon. Alex, Nina, Natalie, and I are going to talk to you guys about cervical traction. We wanted to start with the most common pathology that cervical traction is used to treat, which is cervical radiculopathy that can either be accompanied with pain or can present without pain. So just a reminder, cervical radiculopathy is when there's compression of the cervical nerve roots. C7 is the most commonly affected. Some symptoms we might hear from our patients are that they have pain, sensory deficits, motor deficits, decreased reflexes, or a combination of all of the above. Statistics show that every 83 in 100,000 people will experience cervical radiculopathy, and it's most prevalent in the 5th decade of life. In terms of diagnosing cervical radiculopathy, the gold standard would be either an MRI or an EMG. Since we as PTs won't have access to those in the clinic, they've developed clinical prediction rules, and there are 4 of them. So the first is a positive Sperling's test. The second is a relief of symptoms with cervical distraction. The third is a positive upper limb tension test 1, which is for the median nerve. And then lastly, they will have less than 60 degrees of cervical rotation towards the affected side. If they have 3 of 4 of these, then the specificity is 0.94. And just a reminder, specificity means spin, rule it in. So with a high specificity, we're likely to rule in this pathology for our patient. For treatment, JOSPT released clinical practice guidelines in 2017. And what they found to be most beneficial was mechanical intermittent cervical traction combined with strengthening and stretching exercises, plus cervical and thoracic mobilizations. And as always, they emphasize the importance of patient education.
All right, so we'll talk a little bit about cervical traction. So what is traction? Traction is defined as a mechanical force applied to the body in a way that separates the joint surfaces and elongates the surrounding soft tissues. Traction helps alleviate pressure on nerve roots and soft tissues. It also enlarges the vertebral foramen. It will also help free trapped nerve roots and decrease joint stiffness. Traction can be performed manually by the PT or mechanically, like seen in the picture on the right. So the Neck Disability Index, or NDI, is the most widely used questionnaire today as far as neck pain is concerned. It is used to determine how neck pain affects a patient's daily life, and it assesses their self-rated disability. It consists of 10 questions, and I put a picture of it here on the right. It is separated into 10 different domains. So you have pain intensity, personal care, lifting, work, driving, reading, headaches, concentration, sleeping, and recreation. For scoring, each question contains answer choices scored from 0 to 5, 0 being no disability and 5 being complete disability. For the total score, it can go up to 50. So 0 is no disability and 50 is severe disability. Typically, the score is reported as a percentage from 0 to 100%. The ICC is 0.68, which we learned was moderate to good score. The MCID is the minimal clinically important difference, which is greater than or equal to 7. And this is the smallest change in an outcome that a patient would identify as important.
So now we're going to take a look at the different things you might see with a patient who has cervical radiculopathy. When we're looking at body structure and function, most of these patients will have some sort of cervical spine issue, whether that's in their vertebral disc, facet joints, nerve roots, or muscles and ligaments. And you're going to see those different things pop up through the way that they're functioning, through the way that they're moving. And that's going to be decreased range of motion, abnormal postures such as a forward head or a kyphotic back in their T-spine, as well as hypomobility in their C and T-spine. And not to mention decreased postural strength because their endurance muscles are not activating. These functional impairments will lead to their inability to do certain activities such as driving, reading, reaching overhead, carrying really heavy objects, and sitting at a desk for any considerable length of time, which will lead to their inability to participate in certain things that they may have done, like ADLs or just hobbies and things that they really enjoy, such as our patient Karen, who cannot currently compete in her speed knitting competitions. But if we're looking at the overall population of patients who have cervical radiculopathy, you can imagine that they have a really hard time participating in any sort of upper extremity sport, such as playing tennis or racquetball, and even just doing upper extremity work tasks and going to the gym, things of that nature. So with that in mind, we're going to look at our PICOS question for our patient today. For a 40-year-old female with chronic cervical radiculopathy, will cervical traction, mechanical or manual, with physical therapy provide a clinically significant reduction on the neck disability index compared to cervical physical therapy alone in order to allow Karen to return to competitive speed knitting? With that PICOS question in line, we scoured the PubMed search engine using these article search terms in order to find the best suited articles to help our patient. So let's get started.
The first study we looked at was an RCT done in 2009 by Young et al. And they looked at manual therapy and exercise and mechanical traction for patients with cervical radiculopathy. Their patients included ages of 18 to 70, and there were more females than males. The subjects had to meet 3 of the 4 clinical prediction rules that we discussed in the beginning to qualify for the study. And they looked at both acute and chronic symptoms, but a majority of the subjects had symptoms for more than 3 months. They split the subjects up into 2 groups. So group A received mechanical traction, exercise, and manual therapy. And group B received a sham mechanical traction, exercise, and manual therapy. The group A mechanical traction had 10% of body weight as their force, and it was gradually increased at each session. And the sham mechanical traction group had just 5 pounds of force, and that was constant throughout the whole study. Both groups had exercise that focused on postural stabilization and also strengthening the deep neck flexors. And the manual therapy was left up to the PT's discretion, but it included either cervical or thoracic mobilizations. The outcomes they used in the study was the NDI, and they saw patients for a total of 7 visits over a span of 4 weeks. What they found was that there was an improvement in function, disability, pain, and symptom reduction in both groups. We felt as though there were several limitations in this study, though, the first one being that there was no true control group since both groups received mechanical traction. The sham group just received a lot smaller of a force. And the second limitation was that HEPs were distributed to both groups, but they weren't closely monitored. So we're unsure as to what they were doing at home and how that was being progressed. In conclusion, it's unclear what of the interventions helped improve in both groups, but we've determined that it was probably a combination of all the interventions that led to the improvements rather than just an isolated treatment.
All right, so the study I looked at was one done in 2019 by Appraisal et al., which was a comparison between manual traction, opening technique, and a combination in patients with cervical radiculopathy. They had 39 participants between the ages of 30 to 50, and as Bree mentioned earlier, they had to present with 3 out of 4 clinical prediction rules to qualify for the study, as well as unilateral upper extremity pain, paresthesia, or numbness. And this fit our P well, considering our patient is a 44-year-old female presenting with cervical radiculopathy. For the interventions, they used the intervertebral opening technique, manual traction, and then the third group used both of them. The outcome measure used was the NDI. They had a couple other ones, but we focused on the NDI for our PICOS question. They also looked at cervical spine range of motion. For the results of the study, all groups showed a clinically significant decrease in the NDI score, which is good because 0 means no disability and 50 was high. There was also no differences between each group or between the groups. Some of the limitations of the study was that it had a small sample size. It had also a short intervention period, so it was a total of 9 visits. So they did 3 visits for 3 weeks. They also looked at acute and chronic patients. The study was single-blinded, so the PT wasn't blinded, but the patients were. There was also no exercise intervention or HEP given, so we really couldn't compare that. In conclusion, both manual traction and opening techniques are helpful to decrease cervical radiculopathy symptoms. So I think that it could be something based on patient preference and perhaps use the intervention that they are most comfortable with.
A study done by Bukhari et al. In 2016 was done to compare manual traction versus mechanical traction. In this study, participants were aged 20 to 70 years old, which fits into the patient we have for our PICOS question. And the two intervention groups that they looked at both had mobilization and exercise therapy. The main difference is, like I said before, one had mechanical traction while the other had manual traction. The outcomes used in the study were the Neck Disability Index, and the results of the treatment found that both groups had a significant decrease of NDI scores after 6 weeks, but that the mechanical traction group was more effective at decreasing those NDI scores. The limitations of the study surround mainly that it's a little bit vague in terms of describing patient characteristics, and the exercise therapy was not specified and not listed in the study. However, we can conclude that mechanical traction for cervical radiculopathy patients in conjunction with manual mobilization and exercise therapy is able to significantly decrease NDI scores.
All right, so the last study that we're going to talk about is one done by Fritz in 2014. They looked at 3 different groups: exercise only, which is going to be referred to as group A, exercise with mechanical traction, group B, and exercise with over-the-door traction, group C. The population here was 88 participants that were from ages 18 to 70, with more females than males, so this fit very well with the P of our PICOS question. The chief complaint was neck pain with radicular symptoms. Again, they used the outcome measure of the NDI, and the results here showed that all groups showed a positive, clinically important decrease in NDI score. They followed up these groups at 4 weeks, at 6 months, and at 12 months. And when comparing groups A and B, they found that there was only a statistically significant decrease for groups A and B at 6 months, not at 4 weeks or 12 months. Some of the limitations of the study was that there was no blinding, that patients were able to cross over from one group to another in certain circumstances. 32 patients were lost due to follow-up, and they didn't give a very good reason as to why this was. And also that there were some baseline differences, most importantly, the duration of symptoms. So the conclusion of the study was that manual therapy in conjunction with exercise may provide benefits for patients with cervical radiculopathy compared to just exercise alone. But the study did also highlight that exercise is very important to this patient population, and that even in and of itself, it can help to decrease that NDI score. So from all 4 of these studies, what can we conclude? First of all, cervical traction was most effective when it was in conjunction with other interventions. As we've talked about a lot in class, pairing skilled physical therapy with a modality is very important. And some of the interventions that our studies looked at are listed here. And these really in conjunction with traction help to improve patient outcomes more. Second, mechanical traction was better than manual traction. As we've played around with some manual traction in class, you can tell that you just don't get that same control of force production when you're doing a manual traction versus when you have a patient on a mechanical traction machine. Third, manual traction and opening techniques really yielded pretty similar results. And lastly, patient preference is key to an effective treatment. Looking at what makes your patient feel better, what makes them feel like they're getting the best results, what's reducing their symptoms, that's really important for how to treat them. So taking in all of this into account, we created a specific plan for our patient Karen, and she underwent mechanical cervical traction in conjunction with a tailored therapeutic exercise program just for her. This was performed 2 times a week for 4 weeks, and we found that Karen was able to have a statistically significant decrease in her NDI score. She was able to go back to her speed knitting competitions, and she was able to return to a lot of those ADLs that she was doing before she ever experienced her symptoms. So with that, these are our references. And this concludes our presentation. Thank you so much for watching, and we're here to answer any questions that you might have.